And I've heard you recently say that there seems to be this doubling down on blaming cholesterol for heart disease.
Mhm.
And it was funny. I checked the date on that. The date of that podcast was 2018. So that wasn't
Oh,
even
wow.
like this week or last month. This has been going on for a long time. And I feel like it's really intensifying. So I wanted to definitely spend time talking about your new work with the new group you're with. But I also wanted to cover some of the things that just don't die. They just keep coming up. And I'd love to hear some of your opinions about that. Before we cover that, will you remind our audience how a cardiologist ended up getting involved in the low carbohydrate space?
Yeah, I always wanted to be a preventive cardiologist. When I did my cardiology fellowship training, it was a combined preventive and general cardiology training program. And I just really had this image in my mind that I was going to get out into the real world and just help people with their lifestyle and really not need as many medications and really sort of transform their cardiac health. And I was just falling flat on my face. I mean, was not having the impact I thought I was having with people, and or that I thought I wanted to have with people. So what I was able to do was start Boundless Health with a good friend of mine who was a health coach, and say maybe I just needed sort of more time, more one-on-one time, get them hooked up with a health coach and a trainer. And fortunately for me, he was very knowledgeable about nutritional ketosis, about ketogenic diet. So for a couple of our tricky patients, he said, "Why don't you start a ketogenic diet on this guy?" And of course, my first response was, "I'm a cardiologist, man. I can't do that. I don't want to kill the guy, right? That's against everything I've been taught." But luckily he sort of pushed me, and he, encouraged me to read up on it and look into it. And I was amazed that there was actually literature on this. There are published studies on a ketogenic diet, nutritional ketosis, and metabolic benefits. And it opened up this whole new world. So I tried it on myself and tried it on some patients. And I was all of a sudden starting to see the impact that I wanted to see, that people were losing weight, improving their metabolic health, improving their cardiovascular health, feeling great. And that's the other part, right? Like we talk so much about these health markers and everything, but how do you feel and how do you live your life? And it really was like this aha moment, like, oh my goodness, this is the combination of feeling great, enjoying your lifestyle, and improving your health in ways that I haven't seen before. So that was enough for me to say, not only do I want to use this in a number of my patients, but I want to shout it from the rooftops, because here I was, a very well-trained cardiologist, med school, residency, chief residency, cardiology fellowship, and I never heard of it, right? I never knew it existed. So who else is going to not know it exists? Well, almost 99.9% of the doctors, basically. So that's what really inspired me to want to shout it from the rooftops, to educate people, right? Not to say everybody should be on a keto diet, not to say every doctor needs to use this in all their patients, but to say this is a tool that absolutely needs to be in our toolkit as physicians. So yeah, I could go on and keep answering this question for a long time because I'm so passionate about it, but that's really what got me started.
That's amazing. If you're listening at home on a faster speed, you're going to have to bring this one down to like a more normal speed. You're the only one that talks as fast as I do. I absolutely love it. You delivered a 60-minute, speech at Low Carb Denver, all about therapeutic nutritional ketosis, but it fit into 30 minutes of clock time. So congratulations on doing that.
Thank
No,
you.
it's amazing that you were able to reach those conclusions. It must have been difficult for you to get past your dissonance of your training, right?
Oh yeah. I mean, the term cognitive dissonance completely fits, because I was taught the exact opposite. You cannot eat fat. Saturated fat is just evil, and animal products, forget about it. My fellowship training was in a Dean Ornish style program where, the diet was all about very low fat vegan style diet. And people loved the exercise component. People loved the social component and the smoking cessation and the meditation and stress reduction. And they kind of tolerated as best they could the diet. They didn't love it. So, but the point is that yes, it went against everything I was taught. So there was this moment where I was like, can I really do this? Like, this is not what, this is the opposite. It's not just that like a slight variation. It was kind of the opposite. But again, once I learned that there were studies behind this, and once I saw the practice of nutritional ketosis in action, those doubts faded pretty quickly, because, what I want to do is help people. I don't just want to go through the motions. I want to see results. I want people to change their lives for the better. And when I saw it happening left and right, it's like, all right, I'm in.
Yeah, that's great. No, you can't unsee those results. They're just so powerful, and it's really an obsession that grabs you and makes you share it with other people and continue
Yeah.
learning about it, which I absolutely love. I do want to go back to your training. You've already mentioned cholesterol and saturated fat in particular. Can you tell us mechanistically what you were trained as far as what happens with cardiovascular events, atherosclerosis. We can go whatever direction you like to go with that, and what most like people on the street would think is, heart disease in particular.
Yeah. I mean, what you're trained is if you eat fat, your LDL goes up and you have a heart attack, period, full stop, end of sentence. That's, as simple as it gets. And, I mean, that simply isn't true. We don't really have the evidence to support that. A lot of the evidence comes from these large observational studies where the people eating more saturated fat or eating more fat in general were also smoking more and drinking more alcohol and exercising less and eating more calories in general. And they were just less healthy in general. And then the effect size or the hazard ratio or odds ratio was so small that you really can't use any of that data to say, this is what it means for you as an individual, and this is going to be harmful for you. That level of quality of evidence is not meant to make those recommendations, but yet that's what we have. So that's what we use and say, this must be. And, there are studies then showing if you treat LDL with medications that your risk of a heart attack can go down, again, by a very small amount. But we have to ask, who's the population? What's their metabolic health? What else are they doing with their lifestyles? There's this next layer of questioning that, frankly, we're not so good at in medicine because it takes time, it takes energy. You have to have longer discussions with your patients, and it doesn't fit nicely into sort of a cookbook guideline. So that's what's really promoted. But this concept of metabolic health is something that really was a rare term even 10 years ago, whereas now, fortunately, it's becoming much more common of a term. And you can look at one study, it was published in JAMA, I don't know, a few years ago now, probably, from the Women's Health Initiative, that looking at risk factors for heart disease. And this was like, I should have reviewed the study before this, I apologize, but it was like 10 or more years after an initial evaluation, and who had heart attacks, who lived and who died. And LDL was on the list with a risk of like 1.4, and ApoB, which is sort of a better measure of LDL and cardiovascular risk, was on that list at 1.8. But a marker of insulin resistance was at 6, and type 2 diabetes was at 10. So now all of a sudden, it kind of helps put things into perspective a little bit. Like, what would you rather be focusing on? The metabolic health, which were at 6 and 10, or the one lab value, which was at 1.3 or 1.8. So to me, that's like really eye-opening, that we have to start framing cardiovascular risk in a broader definition, with metabolic health at the center of that definition. It doesn't mean LDL and ApoB are useless and you throw them out, but you interpret them within context of someone's metabolic health and their inflammation, their blood pressure, their family history, the lifestyle they lead, right? It's a much bigger picture, but that makes it a more complicated discussion, and not just, here's your prescription, see you later, which doctors don't want to do. I mean, I don't blame doctors necessarily. They don't want to just be prescription after prescription after prescription, but the system has sort of beat them into it. I know, I was part of that system for far too long, that you have to rush through your patients. You don't have the luxury of time. You don't have the resources for someone to learn about nutrition and exercise deeply. All you can do is give them, your 30-second spiel about what they should do with their nutrition and exercise and hope it sticks. But that's not the right way to help people improve their health. And that's unfortunately the system we're in.